You're welcome back. You're still watching Prime Morning right here on Joy Prime Television. We've gotten to the good living segment where we talk everything health. Remember, it's not going to be static. Obviously, I'm doing this with you. And so if you have any question pertaining to what we'll be discussing, kindly share them with me. We'll be sharing the phone lines on the screens pretty shortly. And so all you need to do is to send that message. Right, that's the number on your screens right now. Send me any questions you have. Doctor is right here. Of course, we will be asking him all what we have to ask him. Now, today we are talking about breast cancer awareness. Obviously, we're in the month of October, which is a month that is specially designated to, promoting everything about breast cancer awareness. And so it's no surprise that we have Dr. Mervyn Boakye Agyeman. He is a clinical radiation oncologist, National Radiotherapy, Oncology and Nuclear Medicine Center, CAF. Is that it? KNTA. Oh, okay, yes, okay. You're welcome, Doctor.
Thank you very much.
Thank you so much for joining us this morning right here.
It's nice to see you.
Awesome stuff. And you're wearing pink.
Thanks. You're supporting everyone. So.
Awesome stuff. Yeah. Now, let's get into the statistics. I mean, every year in, year out, we, talk about the month of October being a month that we used to obviously speak about breast cancer and the fact that a lot of people need to be aware about it so we can cut down the number of cases or the number of times that women get infected. But looking at the statistics, are we improving or are we declining right here in Ghana?
Okay, we are improving to the extent that now people are becoming aware of breast cancer. Okay. So in that sense, we are now having a lot of patient reporting for treatment. But we will say that we are declining, or we are declining. We've not really gotten to a point where we are diagnosing a lot of patients at the early stage. We are rather diagnosing either at the locally advanced stage 3, stage 4, than the stage 1, stage 2, or stage 0, which is the optimal stage 2, because in breast cancer, your stage to some extent will correlate to your survival rate. So unfortunately, we have a big task to be able to achieve that target.
Right. Now, I mean, every time, again, in October, we always talk about breast cancer that has to do with the breast. But is that the only illness that's associated with, the breast?
So if you take the breast, or mostly pathologies within the breast, only 1 out of 10 will be as a result of breast cancer. Okay. There are a lot of things, or what we call benign lesions in the breast. So sometimes you have something called fibroadenoma. Sometimes even with a lactating mother, their breast can become engorged and become infected. So there's a lot of things that can probably lead to breast lesions. But mostly the ones we are worried much about is the cancerous ones, because you can't really, by just examination, differentiate benign from malignant. You have to do further testing to be able to be diagnosed appropriately. So that's the difficult aspect of it.
Right. But let's talk about some of the things people really need to know, the facts that people need to know when it comes to breast cancer, the awareness, and of course the early detection.
So in terms of the fact, as we know the slogan, early detection saves lives. So the earlier you detect, the higher chances of living. Okay. And secondly, breast cancer is not a death warrant, because that's the mentality a lot of people have. So once they notice any lump in their breast, even just the fear of cancer, they rather prefer to stay at home or probably go through alternative treatment until it becomes worse, when they cannot do anything about it before reporting. So early detection truly saves lives. So not every pathology within your breast or any lesion or any lump within your breast means that it's cancerous. Even if it's cancerous, even for advanced stages, now they are living, because there are lots of effective treatments. So they are living for a very long period of time. So even with stage 4, when those who have a disease spread to other parts of their body, most of them live for 5 years. About their probability of living to 5 years, almost like 20 to 30%. So even with effective treatment, and now more effective treatments are being developed. So with time, we are even expecting those figures to rise. But to be able to be sure that, okay, once I go through treatment, I know that my survival rate is very high, more than 95%. it all depends on you presenting early for treatment.
Right. Now, the test that one has to go through to detect whether or not they have a cancerous tumor or something, lump in their breast. I know a lot of times I've heard some health practitioners actually even say that, oh, you can actually even test from the home. You know, you can allow maybe your partner do the test. In fact, I have sat here on the same platform to even ask people to allow their partners help them do the test and everything. But I've been wondering, is that really right? Must you go to the hospital so you get a professional check you out, or you can simply just follow most of the
examination.
Examination.
Okay, so both are required. Okay, one, there is what we call the screening guidelines. With the screening guidelines, that one required a professional to examine, because you want to pick it up at very early stage when it's very small. Sometimes it will be difficult for you to really, or because of lack of experience in examining your breast, it will be a little bit difficult for you. So with the screening guidelines, requires that from age 20, at least every 3 years, have a professional examine your breast. But we also recommend that at least you should do self-breast examination as part of your routine or your monthly cycle, because you may be able to appreciate your breast very well than another person coming to examine. Just before your menstrual cycle, your breast goes through changes. After your menstrual cycle, it comes back to normal. So you are encouraged to start breast examination from day 8 to day 10 after when you start your menstruation, so that at least by that time your breast will be within the normal architecture, so you'll be able to appreciate how it feels like. If you're able to know how your normal breast feels like, once there is any pathology, it becomes easier for you. Yeah, so that's the other, and the main reason we get to day 10, just before ovulation, sometimes your breast may go through changes, which will be difficult for you to really differentiate between normal tissue and abnormal tissue. And all these also have a sort of psychological impact when you notice anything in your breast. So we rather advise that within day 8 to day 10 from your menstruation, at least routinely be examining your breast, so that if you notice anything, you can report early for it to be evaluated. And when you normally report, majority of the time you will be required to do other investigations, like probably doing an ultrasound or mammogram, just to confirm what exactly you are seeing. But those things don't limit or don't give you the final conclusion or the final diagnosis. What you may probably do, if you have a lump, is to have a biopsy done. Because the biopsy is what we'll go and examine under a microscope.
We'll determine whether or not it's cancerous.
Whether it's cancerous or it's not cancerous. If it's cancerous, what has to be done about it? If it's not cancerous, how we can go about with the management.
Right. Now, I have a question from a friend. She says I should ask you, are there any emerging technologies, or therapies in the field of breast cancer research that's showing promise? So
there is a lot of emerging research going on. Okay, even from what we know, from the chemotherapy that we know, from there are a lot of things that are going on just to improve survival, even with chemotherapy. Now we have targeted therapy, we have hormonal therapies, we have immunotherapies, all targeting different types of breast cancer. Because majority of the time with the general population, we look at breast cancers, but different breast cancer have different subtypes. And even the different subtypes, they have different molecular behaviors. So it don't make decisions just based on, okay, this patient has breast cancer. We put in a lot of factors. That's why the histopathology or the biopsy is very essential, because that helps us to know how that particular cancer is behaving in that particular person. And based on that, you tailor your treatment towards that person. In terms of the surgical options, now we are really encouraging more of breast conserving surgeries. Because I think the fear of mastectomy or losing your breast let a lot of people defer treatment. But now, if you report early, you're able to conserve your breast for you, where you just go and take out the lump, and the breast will be in normal place. But the issue is, if it's quite advanced, and more, let's say majority of your breast volume is involved, going to conserve it sometimes become a little bit difficult, because the basic idea is the cosmetic effect from the surgery. So in that case, maybe there will be an option to remove the breasts. But even with that, now we have breast conserving reconstruction available in the country. So patients can also look at that avenue where if there is a need to remove all the breast, remove all the breast and reconstruct a different breast for you.
Now, you're still reminded that you're watching our Good Living segment right here on Prime Morning, and we're having a conversation with Dr. Mervyn, and we are basically talking about breast cancer and the awareness that you need to be aware. You need to visit the hospital, have a mammogram and check your breast to see whether or not you're clear of any cancerous, lumps or whatever that is. Now, Doctor, I have noted on social media so-called cosmetologists or cosmetic surgeon, self-acclaimed, and they'll tell you, if you want a fuller breast, maybe you have sagging breast and you want a more fuller one, you don't have to go through the surgical way. You can come, they would put something over it and almost like a vacuum, and they would pump it out. Before they do, you have your breast is back to being full and all of that. Those kind of practices, I mean, that's just one of the many I have seen. Those kind of practices, do they have any risk attached? And have you had any cases in the hospital where someone comes, probably had gone through a similar procedure and is facing any
so whether
consequence?
Breast reconstruction, whether for breast cancer or for cosmetic effects, I think it's been a lot of research is going into it. So now at least there's not been much of big association with breast cancer itself. So people can have their own breast reconstruction done or augmentation done. But the issue is it has to be safe. So you have to know which side, because majority of the side effects come from the reaction to some of the treatment or the infection that comes alongside with it. But because we have maybe some doctors who are very good with it. So in terms of its correlation with breast cancer, there's no really strong correlation with breast cancer. Because even sometimes when it comes to the breast cancer, those who go through mastectomy to remove their breast, some of the reconstruction may even end up being a little bit similar to the breast reconstruction or the breast augmentation. So those things are safe if you are in the right hand, if I put it.
So I have another question for you, and it says, what role does genetic testing and family history play in breast cancer risk?
Okay, so just about 20 to 30% of breast cancer patients will have a family history. Okay, so majority of patients will not have any family history of breast cancer. Now, genetic testing has become an important integral in breast cancer management because it helps us to really identify or start following a patient quite early. One, if you have a family history, and based on how your family history is, will determine when I should start screening you. Most of the screening guidelines that's in the general public are for those or the average risk patients or those without family history. But if I know that your family history, probably most of them are getting breast cancer at the age of 40, I shouldn't wait till probably getting towards that. I will start doing investigation quite earlier, just because I want to be able to pick it up very early. So genetic testing is becoming an integral part of the breast cancer management. And now I think even within our scope or within the country, we have those genetic testing that can be done, the BRCA mutation that can be done. And sometimes it's not really just about breast cancer, because depending on some of these mutations will give us a fair idea about other cancers that you are prone to. So with a person who have already developed breast cancer, maybe there's a probability that can develop any other cancer. So if you know that there is that mutation, it helps us to monitor you to be able to evaluate everything, so that you don't, or if there is going to be any second cancer, we'll be able to pick it up early and manage it well.
Now, for women, I mean, at what age would you recommend that they start regular checkups?
So the standard is from age 20, at least every 3 years, have a clinician or do a clinical breast examination. So an expert to examine your breast every 3 years. The difficult part now is doing the imaging, the mammogram, because per the guidelines say it's age 40, and these guidelines
age 40.
Yes, and these guidelines were developed for the Western world, where most of their patients are developing breast cancer from age 50. So they are starting 10 years earlier to be able to pick it up very early. But unfortunately, in our environment, most of our women are developing breast cancer from age 40 to age 49. So that means we have to look for our national guidelines, which we don't have any established one yet. So
why don't we?
Okay, all boiled down to data. First, we are using international guidelines, but with time, we are now getting data. Okay, we have how do you call it? The cancer registry that's able to give us a little bit information about the epidemiology of what we are dealing with in our country. So based on that, now that we start having the data, we are then will be able to make some decisions based on whatever data we are getting. Because first the teaching was start screening mammogram at age 40. But because now we know that most patients are developing breast cancer at age 40, then we have to rather go back and sit down to see whether we can do it earlier. Is it 30 or 25? That's the question that's left to be answered here.
Now, you're still watching our Good Living segment. I'd encourage you to send your questions, if you have any, on the number on your screens. Kindly do that. And, of course, I'd be asking Doctor all your questions. But, Doctor, so I know that in as much as breast cancer is a more woman thing, men are also at the risk of, getting infected by breast cancer. You want to tell us about the prevalence of the men's side and how it differs from the women? Okay,
so we have about 1 to 2% of the population will develop breast cancer in terms of the males. And difference when it comes to the subtypes and their molecular subtype, they are basically the same. But the only thing is mostly men tend to have advanced disease relatively compared to women. Or because if you compare the man's breast to a woman's breast, woman has a lot of room for the lesion to grow. So if you are taking, like, let's say a lesion of the size of your thumb, with a woman, it can be there for a very long time before it's really starts invading its normal structure. But because men have limited breast, that small lesion will start to go through the skin or even the chest wall. So it becomes an advanced stage 4 disease. Whilst in a woman, probably that same lesion would have been a stage 1 or stage 2. So that's the only difference when it comes to the staging. Men tend to have a relatively aggressive disease compared to, or a relatively high stage disease compared to women.
So it's actually even much more important for the men to partake in the test as well.
Yes, that is quite important. And because we normally shed more light on females, we hardly talk about the men, because when you are talking about self-examination, everybody is talking about female.
Right.
So, and a man, before even it will come to his mind that, okay, there's a lump there, it's probably due to a miracle or something like that, or someone who probably out of something just at the breast and saw it, compared to women who may probably have other alternatives to examine their breast. And
in terms of the figures here in Ghana, what's it looking like for the men who, unfortunately have been infected?
Well, it's also like 1% of the population.
Okay.
Here. So because you compare most of the data we have for Ghana, I think the new cases per year is almost like that's in general is quite insignificant for men. But the new data every year we are estimating about 4,500 new cases per year in the country, and majority of them are women, with the men being quite low.
So we have a question from Sophie in Kumasi, and she says, "Good morning, Noella. Looking sweet today. Thank you so much." She says, "I want to know if there's a particular way to do the self-examination with people with big top, as in big breast. You know what I mean, because I find it difficult to self-examine myself because of that."
Yeah, so if you are well endowed, mostly it would be best you rather get a clinician to examine.
Okay.
And even with such person, I won't just concentrate on just a breast examination. In between, I'll probably do ultrasound or some alongside with it, because if you are well, even under the expert, in the care of an expert, it's difficult for you to pick up very tiny lesions, because if it's a size of, like, let's say about 5 millimeters, the lesion can be there because you'll be able to, it will feel like the normal breast structure.
Right.
So sometimes it will be a little bit difficult. Okay, so majority of the time with that person, at least get a clinician to examine you, and frequently maybe be doing the imaging alongside, whether ultrasound or mammogram, just to help you pick it up very early.
Right. And we have another question that says, hi, good morning. I'm a breastfeeding mother. Sometimes I feel a sharp pain in my right breast. Could it be cancer?
So, that as I mentioned earlier, when everything that happens in the breast is cancer.
It's cancerous.
Yes. So if you once in a while you feel a sharp pain and it's of concern, it's best you see a professional, let the person evaluate. Okay. And so before you go to the hospital, make sure that maybe that breasts have been emptied, so that at least when you get there, they'll be able to examine it well.
As in, she should squeeze out the breast.
Yeah, either you express or you breastfeed to make sure that it's quite empty.
Okay.
So that once they examine,
it's possible. That's possible.
You have to, because the issue is once there are breast milk stored within it, it's going to confuse. It's going to give a negative findings. So what I'm palpating or I'm touching, I don't know whether it's cancerous or it's not cancerous, or whether it's a lesion or it's not lesion. So to be able to do that, at least you have to make sure that that breast is quite empty. So maybe before the examination is done, you breastfeed, or that day you express, and before examination is done, you breastfeed your child with that breast, so that when they examine, they'll be able to have a better feel of the breast. Yeah.
Oh, okay. We have another question that says, hi, good morning. Please, in 2020, few months after giving birth, I felt a small lump in my right breast close to the nipple area and saw the doctor, went for a scan, and they said it's some of the milk that has piled. 2022, I went for a scan again and they said it's nothing, but I still feel the lump. It's not painful too. It's just there. What should I do? Okay,
so in this case, if you are still, there's lump is still there. Okay, as I mentioned, when there is any lump, now it's 2022 to now, so maybe the person has done breastfeeding, and if it was a milk that was stuck, it should have been regressed by now.
Okay.
So if you are still seeing or feeling that lesion, it's better to rather see maybe an oncologist, for instance, Kolebu.
But she says she has, and they said it's nothing.
I don't know the doctor, because sometimes based on the experience of that person also influence the outcome.
Okay, so she must try another source.
Yeah, so if I'm not correct, I can come to Kolebu. We have a working clinic for breast cancers.
Okay.
Breast patients, so that at least you can have it being evaluated, because that thing I will require a biopsy just to be sure whether it's benign or it's cancerous. If you're in Kumasi too, I think Konfanoche, there is a working clinic which you can utilize for them to evaluate further.
Right. So this one is not in any way connected to what we're discussing, but if you can answer, it says, please, can someone go through chemotherapy while pregnant?
Yeah, so you can go through chemotherapy whilst pregnant, but it will depend on which stage of your pregnancy. Because when we diagnose a patient with breast cancer or like cancer in pregnancy, you need to look at, because you are looking at the mother, the baby, the safety of the medication on both of them. You want a mother to go home with a child. You want to be able to control the disease. So depending on the trimester, we determine your treatment plan. If it's very early or probably midway within the time, sometimes you give some time and give chemo, the patient go and deliver. After that, you continue. If it's getting to the far end of the pregnancy, you rather recommend that go through delivery, or maybe they should induce delivery. Then you'll be able to continue with your treatment. But the safety is safe.
Okay.
There are different medications that are safe in pregnancy that we make sure that with patients who have any form of cancer within pregnancy, at least they can take those medications with no harm.
But is chemotherapy the only way one can, reverse any cancerous,
So we have the surgical options. So we have the surgical option, the systemic therapy. So that's where chemotherapy falls under. So we have the chemotherapy, we have the hormonal therapy, we have the immunotherapies and targeted therapy. So there are lots of medications that are available. But even with all of them, in terms of pregnancy, all of them have their safety in pregnancy. And also, sometimes the patient may need radiation therapy as part of the treatment. Yeah, so there are a lot of treatment options available.
Doctor, there's a message for you. If you can read that for us, please read it out loud so that...
Please, how many times should I suck a breast?
Yeah.
Okay, there is this misconception about breast sucking and
how it helps
reducing breast milk.
Yeah.
I know the men are saying, oh, yeah, but there's no established truth about
right.
that. Yeah. So.
Oh, really?
Yeah. How often, that one depends on you, or how, if your partner will allow, that one depends on you, but it doesn't reduce your risk of breast cancer.
I see. Hi, good morning to you. I'm having some bulky spots. I believe what she means is a lump inside my breast. So that one, is it breast cancer or not? So
I recommend to see a specialist for it to be evaluated, so that based on that, they will be able to come to a conclusion what exactly you are dealing with. Yeah. So,
I mean, let's say someone comes to you, obviously you've done your checks and she has breast cancer. What are some of the support systems or support groups, apart from obviously the chemotherapy and other, stuffs to get it out of hair? Are there any kind of, support groups,
when it comes to
available for people like that?
When it comes to the management, we have what we call multidisciplinary approach to treatment. Okay. Even before we decide that we are going to do surgery for you, chemo, we bring all experts onto the board. We have the psychologists over there. We have the oncologists, the surgeons, the traditional people that we know.
Right.
But we can bring in psychologists. We have nutritionists as part of it. So those who need nutritional advice can see them. We have what we call the navigators, either the nurse navigators, and now we have what we call the survivor navigators, because they've also gone through the treatment. They're able to guide the patient through the treatment. Right. So they try and journey with them because they understand the whole system much better. So there are lots of supports available to help you go through your treatment.
All right. Dr. Mervyn, thank you so much for your time right here on Prime Morning. We've been very educated this morning on breast cancer, especially about the men bit. We hardly pay attention to that aspect, but I'm hoping that would change from today. So once again, thank you so much. And we've been speaking to Dr. Mervyn Boakye Agyeman. He is a clinical radiation oncologist at the National Radiotherapy, Oncology and Nuclear Medicine Center at the Korle Bu Teaching Hospital, I beg your pardon. Thank you so much once again. And of course, that is it for our Living Good segment. We've got more coming up. Stay tuned in to Prime Morning.